Good morning. Good morning.
Or is this my
Good morning, team. My name is Dr. Thuranira Kaugiria. Welcome to our weekly webinar. Today we are second session of the oxygen therapy series. So I'll introduce the panelists and I'll start with Dr. Juma. Start your video, say hi to us.
Morning, everyone.
Okay. Dr. Waweru.
Good morning, everyone.
So much. Dr. Okioma. Dr. Okioma, unmute your mic. Say hi to the team. I think he has fallen off. We'll try to get him. And our boss, Dr. Lois.
Good morning, everybody. Very good to see you again today. We are off to another exciting session. Today, we are continuing the series on oxygen therapy. And we have excellent speakers with us today. For the first session, we'll have a case presented by Dr. Phoebe Juma, who's an infectious disease fellow at the University of Nairobi and a physician at Kenyatta National Hospital. We have two excellent talks on use of oxygen, issues around indication, determining oxygen requirements, and monitoring that will be presented by Dr. Waweru Munyu, who's a pulmonologist at the Aga Khan University Hospital. Then we'll also look at how to deliver oxygen, the various techniques, and how to monitor those various techniques by Dr. Ruben Okioma, who's a critical care specialist at the Nairobi Hospital. So feel free to send in all your concerns and questions, and we'll tackle those at the end. So to start us off, let me invite Dr. Phoebe. Karibu, Doctor.
Okay, thank you.
So Dr. Phoebe will be sharing her screen in just a little while.
Okay, morning, everyone. So Dr. Phoebe Juma, I'm doing the case presentation. I hope I'm audible. Okay. So our patient is GWM. She's a 60-year-old female who was referred to us from a COVID isolation unit at a private hospital in Nyeri. She was a farmer and had no known comorbidities. And currently, she's on her 15th day of admission at Kenyatta National Hospital. So she was previously completely well, and she developed I jumped one slider. So she had presented with a 5-day history of a dry cough, a loss of taste, difficulty breathing, generalized body weakness, chills, fever, and a lack of appetite, which are symptoms which are suggestive of COVID-19. So she was previously completely well, and the above symptoms, once she developed them, were progressively worsening. She had no history of comorbidities like I'd said previously. No cigarette smoking, no habits like alcohol. She had previously been admitted, but only for obstetric reasons, for delivery of her children. So when she was examined, first examined at the private hospital, her vital signs, her blood pressure was 147/65, heart rate of 65. She was tachypneic at 30 breaths per minute, and she was desaturating to 85% on room air. So oxygen supplementation was initiated with nasal prongs, and on 3 liters, they were able to get her up to 95%. The other system exams were normal. On the rest exam is where there were positive findings. She had bilateral crepitations. So they proceeded to do lab tests, HRCT done, was suggestive of COVID-19, and they did a severity score, and it was 12/25. They screened her for diabetes. Her HbA1c was 6.18%. Her random sugar done was 6.8. She had an elevated CRP at 105. Lactate dehydrogenase was 898, was quite high. Her white cell count was within the normal range at 10,000 per millimeter cube. Her platelet count was 322. Her D-dimers were elevated. This is a small error. It was 2.5 milligrams per liter. They also did her thyroid function test, which was normal. Renal function was normal. Her liver function tests were normal. A repeat CRP done later was also elevated at 162. So at the private facility, she received several medications. The duration is unclear, but she received remdesivir. She was started on pirfenidone. She received mirtazapine because she was anxious. She was sorry. She received dexamethasone, she received ceftriaxone, and she was also put on ulinastatin. So her progress at the private hospital, she was there for a duration of about a week, but during which she continued to deteriorate. There was increasing oxygen needs. So her SpO2 at the end of that week was 80% on 15 liters of oxygen via non-rebreather mask. So at this point, they made a decision to refer the patient to a critical care unit, which is at Kenyatta National Hospital. When we received the patient at Kenyatta National Hospital, she was desaturating quite, let me say, severely. Her SpO2s were 50 to 60% on room air. With non-rebreather mask, the maximum we could get to was 78%, and she was in significant respiratory distress. So a trial was made of high-flow nasal cannula to administer a higher amount of oxygen, but was unsuccessful. So this patient was started, non-invasive ventilation was instituted. So with that modality, our saturations were able to go above 90%, which was our target at that time. And we instituted her on Clexane and dexamethasone in addition to symptomatic treatment. So she did well, and after 3 days, we were able to wean her gradually off the NIV back to non-rebreather mask at 15 liters. And she was stable on this, and within 2 days, we were able to transfer her out of the critical care unit to our COVID isolation unit for non-critical patients. So today, this patient, she still complains of difficulty in breathing on exertion, but she has done really well. Well, she was quite weak and bedridden. Now she's ambulant, breathing well on nasal prongs. She's currently on 4 liters per minute and able to saturate at 94%. Yeah, thank you. It's a very brief presentation. Back to you, Dr. Alois.
Thank you, Phoebe, for a really excellent case. And I think you've set a very good foundation for some of the discussion that we're having today. So just before I invite Dr. Waweru to discuss issues around identifying the patients who need oxygen, I just want to make a few comments on this particular case. So one is when a patient comes in, how do we identify the patient who's likely to do badly? Because that is important even as you determine where to manage the patient. So if we look at the patient that Phoebe has presented, one, this was an older female. She didn't have any comorbidities, right? So, but this is an older patient. So with an older patient, you always want to be careful because that's a patient who's at risk for more severe outcomes. So after identifying this patient, the next thing is stratifying your patient. Is this patient asymptomatic or have mild illness? Because those are patients who you can send home. Is this a patient who has moderate illness? That's a patient whom you may consider admitting into the hospital, especially if they have the high risk factors. So a patient who is older, who has certain comorbidities, is a patient who, if they have moderate illness, you definitely want to consider admitting to the hospital. Or is it a patient with severe illness, in which case definitely admitted, or critical illness in whom you will need to admit to the critical care unit. So I'm just sharing a brief chat. There's a team that's been working to develop some guidelines that will be released to you very soon. And it sort of indicates just what are the considerations in stratifying a patient either to mild, moderate, or severe illness or critical illness. So if oxygen saturations are above 94%, then that's a patient with moderate illness. If that patient has risk factors for severe outcomes, you should admit that patient. If you have a patient, oh, it's not showing. Sorry, I've started sharing my screen, but I'm told you can't see it. Let me try again. Nothing? Okay, the screen has refused to come on. So we'll try and sort it out, then maybe at the end of the presentation, we can put it up again. So really it was just looking at stratification of illness and what to do with patients who present with various degrees of illness. So we'll show this towards the end. But the other thing I wanted to comment on about this patient is the issue of what tests are relevant when patients come in. As you notice, this is a patient who had very many different tests. They had a D-dimer, a CRP, they had the HRCT, and they had many other tests. So maybe just to make a comment, some of these tests may occasionally be useful in working up a patient, but they're not mandatory. For example, a D-dimer is expected to be high in a patient who has significant inflammation. For example, a patient who has pneumonia and COVID-19. So doing it at the outset is not necessarily useful. A CRP may be useful in a patient who's rapidly deteriorating, in whom you need to determine whether there are other therapies that you may consider, but it is not a mandatory test for every patient who comes in. HRCTs are probably indicated in patients either with severe illness who are not improving or patients with critical illness. It is not mandatory that you do a HRCT for all patients. So that's important because there are facilities where almost every patient who walks in through the door ends up getting a HRCT. So those are important considerations to have. In the previous webinars, we've discussed the issues around what therapies are useful. As you noted, this is a patient who had multiple therapies. Again, important one, the patient had remdesivir. So remdesivir may have some role in patients who have severe, not critical illness. It has no impact on mortality. And it's important to know that, especially when you're going to discuss issues of therapy with your patient. The patient was also started on ulinastatin, and looking at all the data available on COVID treatment, ulinastatin has not been extensively studied. We have no data on it, and it should not be used in patients with COVID-19. So I will stop there for now. The next considerations are, this is a patient who comes in. Does the patient require oxygen? When do they require oxygen? How do we start them on oxygen? Once we start them, how do we monitor? In a patient like this one who was started on non-rebreather, taken to high flow nasal cannula, taken to non-invasive ventilation, how do you determine when to move from one to the next? And those are the very issues that we'll be looking at today. So allow me now to invite Dr. Waweru to start his presentation. Dr. Waweru, karibu.
Thank you, Lois. Please start my video.
Your screen has come up, Dr.
Can you
Waweru.
see me?
We can see your screen, your slides. Maybe you can put on slideshow.
Can see it. That's okay. Good morning, everyone. And I'm grateful for being asked to talk about oxygen therapy. Thank you, Lois and team. So as we all know, oxygen is one of the key drugs that we use in patients who have COVID-19. Sorry. I am not able to move my slide. Is it on my side? Oh yeah, there we are, So as we all know, oxygen is a life-saving drug, and this drug should be promptly administered to those people who need it. And as we go along, we'll discuss who are those people who need this oxygen. Let us also remember that oxygen is an expensive drug. You have seen some careers because they could not get enough oxygen for people in their hospitals, both locally and internationally. So it is not a cheap drug, whether we are receiving it through cylinders or concentrators or oxygen plants. It is an expensive drug and therefore should be handled very carefully, and we should be economical with it so that we can help as many patients as possible. Even as we talk about oxygen, we should remember that as with all drugs, it should be given to the right patient, and the bulk of this presentation will be looking at who is the right patient. We should also do the right assessment, and we'll discuss a little about that. As far as dosing is concerned, we do know that we have the natural dose, which is 21%, but in those patients who are having hypoxemia, for whatever reason, we need to increase the amount of oxygen they are using. And I know one of the speakers will be discussing how to deliver different doses, how to measure different doses. So starting from prongs, going on to simple face masks, the non-rebreather masks, the high flow nasal cannulae, as well as non-invasive and invasive methods of delivering variable quantities of oxygen. By talking about the right route, we are here talking about the device. These are the devices which will be discussed much later. Whenever we give oxygen, it is important that we document, one, the reason why we are giving the oxygen, number two, what our achievements are with that oxygen. As Dr. Phoebe has shown, the patient came from Nyeri. By the time she arrived in Kenyatta, it appears she was on room air, which is quite unusual. But we should always document both for ongoing care and especially when transferring patients, what we are giving and how much we are giving, so that we can have a good handover. We do know that a few patients have died in this country when they are transferred from one hospital to another one with either inappropriate route or rather inappropriate device, or the oxygen gets finished in the way and the patient arrives in the other hospital without oxygen and in extremis or even dead. We should start oxygen at the right time. As Dr. Lois has mentioned, patients who have saturations above 94 really do not need oxygen. But we also need to ask ourselves, what is the cost of getting this patient at 94? Some patients are in such respiratory distress that we have to think of how we can reduce the work of breathing, and we may need to give a little oxygen for those patients. Patient education has become very, very important. These days, our patients are well informed, and some people will even discuss with you about the problems of getting oxygen. So it is very, very important that we educate the patient, the indication why we are giving the oxygen, what our expected goals of that oxygen therapy is, what we will need to do if the goals are not achieved. For example, we may need to move from prongs to mask. Sometimes we may need to move from non-invasive to invasive methods of ventilation or oxygen delivery. Patients and their families, you need to be educated about all this so that they can cooperate. Remember, these days we are also treating very many patients at home on oxygen. These are patients who buy cylinders or they buy concentrators, and they sometimes choose to receive oxygen at home. It is important, one, we train them what this oxygen is, what the dangers of excessive oxygen are, what the dangers of hypoxemia are, when to seek help, when to be admitted in hospital. Remember, at this point in time, very many patients are afraid of coming to hospital. So we need to empower them by educating them when it is dangerous to stay away from hospital and when they need to come in for further care and further monitoring. We also must remember that even when patients are receiving oxygen, we need to continually evaluate them, monitor them. And by monitoring, we generally will use pulse oximeters, whether the patient is in the hospital or at home. But when they're in hospital, we will also have in some hospitals the capacity to do blood gas analysis, aspect of checking not just the oxygen level, but also the other related things with respiration, such as carbon dioxide, bicarbonate, pH, and so on. And that can allow us to make certain decisions regarding the patient's respiration. Finally, we have to remember that a patient has a right to refuse the medication or the advice we are giving. And we have seen situations where patients completely refuse to receive oxygen. We have had situations where patients actually get adverse outcomes because they refuse to receive oxygen. The refusal sometimes is due to anxiety. Remember, some people think that you can get addicted to everything, including oxygen, and they are afraid of the addiction more than they are afraid of dying from hypoxemia. So the issue of education becomes very, very important. The other thing is that there are patients who have decided that I do not want to go on a ventilator. Maybe they have other comorbidities, or maybe they are at such an age that they have made such a decision. What we need to do is always make sure that the patient and the relatives understand the likely repercussions of refusing oxygen, and they do know what will happen if that happens. So always take time to educate your patient about oxygen treatment. So this talk has to do with COVID-19, but many of these patients will have other conditions. Specifically, let me talk about cardiac conditions and other chronic respiratory conditions. For example, a patient who has chronic obstructive pulmonary disease will be happy with a saturation of 88%. So when they have COVID-19 and they come into hospital and you find that their baseline level of oxygen saturation is 88%, and currently they are on 88, they are doing 88%. This is a patient whom you may not necessarily administer oxygen to, because they are at their baseline and their bodies have adjusted to that baseline. And in this cohort of patients who have COPD, they may have a problem if you give oxygen too well. For instance, they rely on their hypoxic drive to breathe. So if you give too much oxygen and you are aiming for saturations of 94, 95, 96 and above, you may find that these patients stop breathing, and that now becomes another problem. So not everyone should have the 90 to 94% target. Let us also check the other comorbidities these patients will have. Now, there are many patients who also have profound hypoxemia. Dr. Phoebe's patient did not have this happy hypoxemia, but there are patients whom you'll find they have saturations of 60, 70%, and they're looking at you and they're wondering, why is this doctor telling me to receive oxygen? I'm quite comfortable. So let us go step by step and find out what is it that leads to hypoxemia in COVID-19 patients. COVID-19 patients have pneumonia. Those who have hypoxemia will have pneumonia. And the hypoxemia will be as a consequence of the following processes. Number one, there will be intrapulmonary shunting. That means that blood gets from the right side of the heart to the left without passing through aerated alveoli. And therefore that blood does not pick any oxygen. It may release a bit of carbon dioxide, but it does not pick any oxygen from the lung. And this is what we call intrapulmonary shunting. The reason the alveoli will not be able to transfer oxygen is because when one has pneumonia, the alveoli is filled with debris. This is things like cells, plasma, and other clots within the alveolus. And all this will form a barrier between the air and the endothelial surface and the blood flowing within the small capillaries, and therefore blood will not flow. Rather, air will not move from the alveolar space into the capillary. The second thing is that there is loss of lung perfusion regulation. Normally what happens in the lung, if a portion of the lung does not have access to oxygen, the natural reflex is for the blood vessels in that area to go into spasm. This does two things. Number one, it reduces the intrapulmonary shunting because it reduces the amount of blood flowing into that area which has no oxygen. And number two, blood is redirected to well oxygenated alveoli. And therefore there is the reduction of this process we talked about, that is the intrapulmonary shunting. Number three, we do know that COVID-19 triggers significant procoagulation within the blood, and that leads to small microthrombi forming within the capillaries of the lung. When these microthrombi form, they obstruct the easy flow of blood within the capillaries, and that also impairs the exchange of oxygen from the air into the capillary blood and flow of carbon dioxide from the capillary blood into the alveolus for excretion. And finally, we do know that when there is inflammation, alveolitis, that is inflammation of the alveoli, there is edema and thickening, and that reduces the ability of oxygen to flow from the alveolar space into the capillaries. And that is what you call impaired diffusion capacity. All these things lead to reduction of uptake of oxygen from the lung into the bloodstream. You can see my village is peeping there. So there is impairment of flow of oxygen from the alveolus into the capillary. And the end result is that the patient ends up with hypoxemia. Now, I had already talked about happy hypoxia, which many of you are aware of. And the thought is still not clear why this not aware of it. But there are certain theories or hypotheses which have been brought up to try and explain this. Number one, in these patients who have COVID-19, there is an effect of the COVID virus on the blood, on the nervous system. If you remember, there are things like loss of smell, loss of taste. These are functions of problems with the nervous system. And what happens is that the nerves which carry taste go also to the area where nerves that carry a sensation of hypoxia go in the brainstem. And therefore, this area, it's called the dorsal nuclei. This area, if affected, we affect taste and we also affect the body's sensation of hypoxia. And therefore, the patient will not respond normally to the hypoxia. They will not have tachypnea. They will not have the anxiety that comes with hypoxemia. And so this patient will not be aware that they are hypoxemic. And this is dangerous because when patients are not aware that they are hypoxemic, they will not happily take oxygen. They can see the readings are low, but they feel nothing. So they will not take oxygen. This has a significant effect in those patients in the ward. So you have to really talk to them and explain to them why they need oxygen. Number two, patients at home. Because patients at home may not have someone to keep telling them, use your oxygen. If they are not measuring their pulse oximetry frequently, they may end up staying in hypoxemia without realizing it. And this can have a profound effect on their outcomes. Indeed, there has been a study which showed that when patients have been admitted to hospital, many of them will not know they have, up to 40% may not know that they are hypoxemic. And even when you are discharging patients, it is important to assess that patient by exertion. Sometimes you ask them to do a few sit-ups on the bed, and you find that although the patient has not required oxygen in the preceding 24 hours and you are ready to discharge them, the moment you exercise this patient, you notice that their oxygen saturations drop significantly. There are some who will even drop to the 60% range. And that is not a patient who is safe to go home. You will need to educate them. They may need to get an oxygen source for home use, or you keep them a bit longer in hospital until once they exert themselves, their oxygen levels are not falling significantly. So when we are sending patients home, let us always assess whether they are home safe by exercising them and seeing how low their saturations go. We have already discussed about this. I mentioned about the reason why oxygen is not getting into the bloodstream. This is the edema, and that we see as ground glass opacification within the on the CT scan. That also has to do with alveolar filling with debris. We've already talked about pulmonary shunt. Normally, when this happens, a person develops rapid shallow breathing. But in the case of patients who have COVID-19, because they are breathing fast, their carbon dioxide goes down. And hypercarbia is one of the reasons that triggers a respiratory response of deeper breathing and faster breathing. And since the body's CO2 is normal or less than normal in these patients, the central chemoreceptors are not triggered to cause a tachypnea and a sensation of dyspnea. So these patients end up with suboptimal ventilation. They may end up with cyanosis due to the low oxygen level. Because they have a preserved brain blood flow, You remember when one has hypoxia, the brain blood vessels dilate. So if they have a preserved brain blood flow, they don't have a sensation of dyspnea. And this can explain why these patients have hypoxia. So this is just a summary of what I have discussed about the petrosal ganglion and the fact that if it is affected, then the impulses from the carotid body will not trigger a response in the respiratory rate and a sensation of dyspnea in these patients. So let's go now to why do we give oxygen therapy in patients who have hypoxemia? The most important reason is to relieve hypoxemia and assure that there is enough oxygen going to all the tissues, especially the brain, the kidney, the heart, the lung itself. And this helps prevent some of the complications of severe hypoxemia. We should always give oxygen in such a way that we do not allow excessive CO2 accumulation. And here what we think about is patients, for instance, who have COPD. When we give too much oxygen, these patients will lose their hypoxic drive. They will breathe less efficiently in that their respiratory rate will come down and their tidal volume will also come down, leading to further carbon dioxide accumulation. And this can cause CO2 narcosis. And this can end up causing a significant impairment of their breathing. So let's select our patients properly even when you are giving oxygen. The other reason we give oxygen therapy is to reduce the work of breathing. And we'll talk about work of breathing later on. For us to achieve adequate oxygenation, we must make sure the other things are working well. For instance, if a patient has bronchospasm, we need to give that patient adequate bronchodilators. And remember, COVID-19 is very well known for causing bronchitis and bronchial spasm. And we also do know that patients who have had COVID-19, as part of the post-COVID syndrome, some of them are presenting with first-time onset asthma. And this is something we have also seen in our practice. Therefore, if a patient has this bronchitis and they are wheezing, and this is due to the COVID-19, let us manage that adequately. One other aspect of oxygen therapy is maintaining efficient and economic use of oxygen. We cannot overemphasize the cost of oxygen. And this therefore means we have to titrate our oxygen properly. We need clear goals of what we are aiming for. And generally we'll talk about saturations of 90 to 94% in these patients who are getting the oxygen. And therefore, if a patient's lungs are improving, let us start weaning off or reducing the dose of oxygen that we are giving to just maintain the oxygen between 90 and 94, because keeping it much higher has no major benefit. One thing I must mention is that even when our patients are maintaining a saturation of 90 to 94, oxygen requirement increases with exertion. So when these patients are doing their physiotherapy, they are walking in the exercise area, we must ensure that even when they are walking, they have adequate oxygenation. So they may need to walk around with the small cylinders or even with their concentrators to ensure that they are not getting excessively hypoxemic. Even as we talk about oxygen therapy, there are certain things we need to remind ourselves about. One is the fraction of inspired oxygen. This is the portion of the air that one is breathing in that is comprised of oxygen. And we can talk about anything from 21% up to 100%, depending on a patient's requirements. Where we are able to do blood gases, we can also check the partial pressure of carbon dioxide in arterial blood. This is after doing a blood gas analysis. And this is used to assess the adequacy of ventilation. When it is high, it means that the patient is having less than normal ventilation. And when it is low, that patient is breathing too fast or too deeply, and therefore we may need to slow down, especially if we are using a ventilator for this patient. Then we have the partial pressure of oxygen. This one is similar to the SpO2, but here this is a reading we get once we get the blood gas analysis. The same applies to the saturation of oxygen in the arterial blood. This is from a blood gas analysis. For most of us, we will be able to do the SpO2, that is arterial oxygen saturation, done via pulse oximetry. This is a standard. It should be available in any unit that is, one, assessing patients who have pneumonia, and number two, in places where oxygen therapy is given, because it will help you titrate the oxygen. It is also important to give patients who have COVID-19 pulse oximeter when they are going home, even when they are mild, because we do know that sometimes the COVID-19 pneumonia gets worse, and the patient may be in the hypoxia group, and therefore we will not realize that their oxygenation is so poor if they are not doing objective measurement of their oxygen. So it is important that whenever we are sending patients home, even when they have mild disease, we ask them to get a pulse oximeter. Hypercapnia is an increased amount of carbon dioxide in the blood. This usually reflects less than optimal ventilation. Hypoxemia is low arterial oxygen tension within the blood, and this we pick either by pulse oximetry or by blood gas analysis. Hypoxia, on the other hand, refers to the level of oxygen at the tissues. This can only be measured in certain research labs, not in the general practice. So what we'll be talking about mostly is hypoxemia, that is low arterial oxygen tension in the blood. Now, who is the right patient? Who are the people who require oxygen? Let us remember that oxygen corrects hypoxemia. It does not do much for breathlessness. So in a patient who has breathlessness but has no hypoxemia, adding oxygen to this patient has not been proven to have any consistent effect on the breathlessness. And by identifying that my patient has breathlessness but is not hypoxemic, we will avoid giving oxygen to people who will not get benefit from the oxygen. Now, number two, oxygen helps with hypoxemia, but does not correct the reason why the patient developed hypoxemia in the first place. So it is very key that we always look at, why did this patient get hypoxemia? Is it because of pneumonia? Is it because they have a pulmonary embolus? And this is a frequent finding in patients who have COVID-19. Is it other reasons? For example, you may have a patient with mild COVID-19, but they are known to have hypoxemia from COPD. So by sorting out the COPD, we may find that the COVID-19 didn't really cause the hypoxemia in this patient. So look for the cause of hypoxemia and correct it even as you give oxygen therapy. For patients who are receiving oxygen, let us monitor them by using pulse oximetry. And blood gas analysis is a good thing that can be done, especially now that many hospitals are developing intensive care units. They should also invest in a blood gas analysis machine, because it will help titrate the kind of treatments and interventions that we do for this patient. And in general, pulse oximetry should be available in all hospitals, because now the gadgets are cheaper. In fact, you can find gadgets being sold for even 2,000 shillings, and most hospitals can plan and get this, and it will become a standard as the fifth vital sign after respiratory rate, BP, pulse, and temperature. Pulse oximetry, especially now that we are dealing with COVID-19, should be considered an essential part of patient assessment. What are the clinical symptoms of hypoxemia? Because most times patients will present to us because they have noted something unusual. And for patients who have profound hypoxemia, you can notice a change right by looking at their skin or their conjunctiva, where they become bluish. This is in those patients who have hypoxemia, but very, very rarely, as I said, I'll be talking even about patients who are not hypoxemic due to COVID, there are patients who will come in and they are looking cherry red or bright red, especially in patients who have carbon monoxide poisoning. In that group of patients who have carbon monoxide poisoning, the pulse oximeter will not be able to pick the hypoxemia, because the pulse oximeters in general use the red color to determine whether a patient is hypoxemic or not. So in this patient who has hypoxemia due to carbon monoxide poisoning, maybe after a house fire or a petrol station fire or something like that, remember that your pulse oximeter will not inform you about that. Number two, and a very frequent complaint in these patients is headache. Many times you'll find you discharge a patient who had COVID-19, required oxygen, and after 2 days they call you and they tell you, hey, Daktari, I'm having severe headache. And you will, if you ask them, you will discover that the real reason for the headache is hypoxemia. So headache is a common symptom. And the other thing that may happen is CNS disturbance, such as visual disturbance. Some will be so profoundly hypoxemic that the brain will not be working well and they may come in confused. They may also have coma. Cough is another common symptom for hypoxemia. In patients who have COVID-19, they'll cough because of the pneumonia. But you'll notice that in many of them, the cough becomes so much better once you give them the oxygen, especially if they have hypoxemic. And we do know that cough is one of the symptoms of hypoxemia. There may be cardiovascular changes, such as a very fast heart rate or a very slow heart rate, especially in profound hypoxemia. And this must be recognized not to be due only to the inflammation or the pneumonia, but also to the degree of hypoxemia. And the moment you correct the hypoxemia, the fast heart rate improves or the slow heart rate also improves. Shortness of breath and rapid breathing are natural reflexes to hypoxemia. Patients may also have wheezing or sweating. Then we can check for signs when you are assessing this patient, and patients who will develop confusion or impaired memory or impaired cognition. We have seen patients who almost become psychotic because they are hypoxemic, especially in the elderly. Let's recognize this not to be as dementia, which occurred over 2 days, but due to the effects of hypoxemia and brain dysfunction. By the time a patient gets into coma, this is a profoundly hypoxemic patient, and we need to act very, very fast for this patient. Asterexis, this is the flapping tremor, also found frequently in hypoxemia, but more common in patients who have hypercarbia. So if you find it, please think about hypercarbia. We've already talked about the cardiovascular changes. By the time your hypoxemic patient is getting low blood pressure, it means that the heart is severely impaired, and therefore that is a patient who is an emergency and needs to be taken care of in a monitored area. Cyanosis and sweatiness, we've already talked about. Frequently in COVID, patients will present with fatigue and lethargy. We do know that the virus itself, by affecting the neuromuscular system, can cause fatigue and lethargy, but hypoxemia also is a key contributor to that fatigue and lethargy. We usually will recommend oxygen in patients who have saturations less than 90 to 92%. In patients who have COPD, we've already alluded to that, saturation less than 88. In patients where you're able to do a blood gas, the cutoff is usually less than 60 millimeters of mercury. Patients who have severe trauma also will require oxygen, acute myocardial infarction, and even post-anesthesia. This is just for your information. Now, the targets of oxygen therapy, basically, we are trying to correct the hypoxemia, and the target is to achieve an oxygen saturation above 90. If one is able to do a partial pressure of oxygen, then we can accept a level above 60 millimeters of mercury. But let us also remember that in these patients who have very severe COVID-19, they also have severe acute respiratory distress syndrome. And these are targets which sometimes we are not very tight about, For example, if we have a patient on very high settings on the ventilator and we are achieving 88%, and we do know that if we apply more positive airway pressure or we apply more oxygen, we are causing harm. We may sometimes, based on the patient's other general condition, we may sometimes accept targets of even lower, like 55. You may sometimes walk into a ward, you find a gas of 85, but the patient, the oxygen is 55, and the patient is quite comfortable. So in such kind of patient, you may, on a patient-by-patient basis, decide that I am not going to aim for 100% oxygen correction, because of the cost, the physiologic cost in terms of pressure, in terms of the amount of oxygen that this patient will receive. The FiO2, if it is very high for a very long time, can also cause harm in the lungs. How do we monitor oxygen therapy? Generally, we should be guided by objective assessment of its effect. The key thing is the oxygen saturation. If you are achieving saturation of between 90 to 94, we are happy. And if a patient has persistently shown a saturation of 94, 94, 94, you can consider reducing the amount of oxygen you are giving. For instance, if you have a patient receiving 5 liters via nasal prongs, and the whole of yesterday he was on 95%, today you can try and come down to 4 liters. If the patient's saturation drops to below 90%, then you know you've gone too far and you can go up to 4.5. And you do this trial periodically, and as your patient gets better, you can slowly wean them off the oxygen. We have some patients whom we are managing at home, and this education has to reach to the family and the caregivers that the patient's oxygen levels targets are this, and if you achieve that target for a given period of time, then you can start reducing the amount. Note, please inform the family or the caregivers that if the patient is doing exercise, the oxygen saturation will drop because the demand has increased, and therefore they may need to adjust the amount they are giving upwards, achieve the 90 to 94 during exercise, and after exercise, give the patient maybe half an hour. When they have rested for about half an hour, reassess again, see if they still need the new level, or you can go down to the previous level that you are using. And as we know, the ways in which we monitor oxygen level is by pulse oximetry. I have shown a picture there of commonly available pulse oximeters, which we can even ask families to get to monitor their patients who have been diagnosed with COVID, whether they have an oxygen requirement or not, because sometimes COVID gets worse before it gets better. In places where we are able to do blood gas analysis, that is an example of a report that one can get, and that is a useful test because it will help one titrate the oxygen requirements even easier when the patient is in the hospital. Not all patients require blood gas analysis. Generally, we do blood gas analysis in those patients who are either deteriorating or are already on supported breathing, either by non-invasive ventilation or invasive ventilation. The other thing we can do when you have a patient who is on a ventilator is also to monitor the tidal volume. Some patients have such severe lung involvement by pneumonia, such that the tidal volume, for you to achieve a good tidal volume, you need very high pressures. But as the patient's lungs improve, their lung compliance improves, and therefore you may need to start reducing your pressures when you notice that you are getting excessively high tidal volume. The same thing applies with the ventilator rate. If you find your oxygenation is okay and your carbon dioxide is too low, then you may decide that probably the ventilator rate is too high and you start reducing it to maintain the carbon dioxide and the oxygen within the normal range. In patients who have hypoxemia, and we do know that many of them respond by having a high pulse rate, and some of them you have high blood pressure, as you improve the oxygenation, the pulse rate will quickly come down, the blood pressure will also quickly come down. We had talked about work of breathing, and really we spend a lot of energy to breathe when we are unwell. Normally, we spend between 1 to 3% of our daily body energy production on breathing. But when a patient has hypoxemia, they have pneumonia, they have other lung conditions, the work of breathing can be very demanding on the body's energy production. It can go up to 50%. What this means is that we must also look at how we are supporting the patients early so that we can reduce the work of breathing. And secondly, let us look at the caloric requirements of the patients. Sometimes patients are on gadgets and we forget to feed them. For instance, a patient on non-invasive ventilation, unless you think about feeding them either through nasogastric tube or peripheral intravenous feeds or even central intravenous feeds, you may find a patient is not meeting their daily energy requirements. And at the end of a week or 2 weeks, you find your patient has become very, very wasted. Please remember to give your patients adequate caloric requirement, meet their caloric requirements so that we don't end up with other problems like bed sores, patients who are wasted and so on. Now, in patients who have required supported breathing, for example, ventilators, and they have been on the ventilator for a long time and their work of breathing has been high, at the end of the day, we may find that it becomes difficult to liberate them from the ventilator because we have no muscles. They have been on the ventilator so long, their caloric requirements has been too much, and therefore they have wasted away, their muscles have wasted away, and therefore it becomes very difficult to rehabilitate these patients even after we get them off the ventilator. So this is one of the available algorithms which one can use to determine how oxygen therapy. And the general principles are that oxygen therapy is guided by the respiratory rate, oxygen saturation, and assessment of breathing pattern. We've also talked about the work of breathing. Then we always educate our patient that we are giving oxygen to meet a certain requirement. So always educate your patients, and that target mostly will be between 90 to 94%. So if we find that our patients' oxygen saturation is low, they have a high respiratory rate, or they have an abnormal breathing pattern, we have to determine, are these patients having, one, a low saturation and a low respiratory rate? If this patient has very low saturation and low respiratory rate, then this is a patient who is unable to respond to the hypoxemia. And this one we need to quickly decide whether they need ventilation or otherwise. If our patient saturations are maybe above 88%, we do a gas and we find that all those are good, then we can decide to start with just nasoprongs. The patient is awake, and once we start the oxygen saturation, the saturations easily reach the 92, 94%, then that's a patient who does not need further blood gas analysis, and we can continue with the oxygen via prongs and monitor going up or down depending on how the patient responds. If, however, when we start the oxygen at 2 liters, they are not responding, you go up to 4 liters, they are not responding, then to 6 liters, then you know this is a patient who needs maybe a mask. If when you use your mask, the patient does not respond, please consider using non-rebreather mask, and you may even require to consider non-invasive ventilation or otherwise. On the other hand, if a patient has saturations above 92%, they are breathing well, they are talking to you, they are completely awake, that's a patient who may not need any oxygen, may not need any blood gas analysis. And for this group of patients, you just monitor them over time, making sure that their oxygen levels are remaining above 92 and their respiratory rate is not going above 25. And if your patient maintains those levels, then you do not need to do anything else as far as oxygen therapy is concerned. Remember, you have to look at the reason why their oxygen levels were low in the first place. For those patients who are in this group where the saturations were good, but then you find that they are deteriorating, then match your response to the patient requirement. And I would urge people to look at this at their free time because it's quite detailed and it gives a very good flow of what we should do at every contact. The involvement of the respiratory team or the physician is important so that they can fine-tune the decisions that are being made. Now, let us remember a few special situations. Number one, the chronic hypoxemic patients, for example, with COPD, and I've discussed this a lot in the presentation. Number two is that group of patients who are on oxygen at home, clear education of targets to the family or the caregivers, and a way of contacting the clinician so that if things are not going well, the interventions can be timely. And number three, let us remember to wean off oxygen in those patients, whether they're in hospital or at home, as and when their clinical situation improves. And with that, I think I come to the end of my presentation. Thank you very much.
Thank you so much, Dr. Waweru, for an excellent presentation. I think you highlighted the importance of understanding the physiology so that we know why we're doing what we do and the issues of monitoring. So there are a few questions that will come in, but we'll take them all at the end of the session. So for now, allow me to invite Dr. Ruben Okioma for his presentation. Dr. Okioma, karibu. Dr. Okioma, you can hear us?
Yes,
we can
yes,
see your
yes,
slides. Okay, you can put on slideshow.
That's what I'm doing next.
Okay. Yeah, that one.
I hope you can see the slide on your side.
Yes, thank you. We can see them well.
And is it moving?
Yes, it has moved.
Thank you very much. Thank you everyone for attending this discussion, and thank you, Dr. Waweru, for a wonderful recap or introduction on oxygen therapy. It's my privilege to discuss the following aspects of oxygen therapy with you. And this is in the context of COVID-19. But as Dr. Waweru has mentioned, we have to think, or we have to always remember, these are patients who have other comorbidities, or they're just a select of the population where you expect quite a number of other prevailing concerns. We look a lot at prescribing oxygen and also the devices that we use, how we monitor the oxygen therapy, and a few ideas on how to improve oxygenation. So oxygen is a big deal, and Dr. Waweru has mentioned that it is a drug which we must use as such at the right dose, right time. That was quite well elaborated. And looking at what is available data on our use of oxygen in the healthcare setting, it is obvious that most doctors and nurses do not understand properly how to use oxygen. In most cases, in more than 42% of hospital patients, there is no prescription, which means there is no indication of what dose, the duration, and the targets. And even in situations where there is a prescription, there's a big chance that the patient may not get what has actually been prescribed, with more than a third of those patients without a prescription also being out of target, meaning they're getting what they are not supposed to get. The aims of using oxygen in the emergency setup is to potentially correct harmful hypoxemia. We have said, or Dr. Waweru has also mentioned, that it may not alleviate breathlessness only if they are severely hypoxemic, but that is not something that has been proven in non-hypoxemic patients. Having said that, we have to understand the physiology of oxygen and just gaseous exchange in the acute setting vis-a-vis the acclimatized situation. If you have sudden depressurization in an aircraft at high altitude, then patients would become unconscious in less than 60 seconds due to significant hypoxemia. But with acclimatization, which enables mountain climbers to actually climb to Mount Everest, where the oxygen tensions are very low, there is that advantage that your patient may do better if they are more used to low oxygen saturations. And that's why COPD patients, for example, we aim at lower targets, as quite well elaborated by my previous speaker. There's a big fallacy regarding oxygen therapy, and this is in regard to is it entirely harmless? And the answer is no. Oxygen misuse has lots of harm, and the reason for this is there's little increase in oxygen carrying capacity if your SpO2 is normal. So if you have a normal SpO2 and you're continuing to increase the oxygen that you're giving, then it is of no use. And this is based on the oxygen hemoglobin dissociation curve, where you find that by the time you get to between 85 and 90, it doesn't matter how big the difference is in terms of the partial pressure of oxygen. So supplemental oxygen should be given when the SpO2 is only below the target range. So how do we prescribe oxygen? Ideally, oxygen should be prescribed like any other drug. You may use a paper chart, or as a hospital, as an institution, you can come up with a paper chart. And we have two main groups of patients. The first group are the COPD patients, where we have already been told our targets should be much lower, 88 to 92%, and the normal population where the target saturations are 94 to 98. If there are any other specific situations, then that can be indicated. And then we would have to talk, of course, of what device we are going to use and the flow rate, and someone to sign for that. Some institutions have electronic prescribing charts, which are, of course, easier to use. And in the era of COVID, where we are avoiding lots of paper, then this would be a good thing to think about. The good thing with this is that it can be connected to the monitoring, central monitoring systems, and you can actually get alerts or alarms when you are off the target range. So the prescription should be given by the clinicians, and then we have the nurses and the professionals allied to medicine use appropriate devices and flow rates to maintain the saturation within the target range. Remember, once you have achieved the target range, then there has to be a consideration of whether you want to start weaning that patient down or not. Looking at the evidence available in terms of oxygen use with prescriptions, the UK has done a lot of work, and this is basically what has been published. In terms of there being a prescription, and it's good to note that where this has been a deliberate move, that the number of patients on prescriptions, there's been a significant increase in terms of the percentage, from just 32% to 57% within a span of 7 years. This is just a summary of the 4,000 plus patients on oxygen with a prescribed target range, and they were looking at having a prescription. Does it guarantee you're going to get the targets? And this is a summary of that. 69% of these patients were within range, 21% were above, and 9.5% were below the target range. Having said that, we have to look at the various patient populations, which I think Dr. Oero has attempted to elaborate. We have the ICU patient who is on mechanical ventilation and what kind of targets we want to achieve. Those with COPD, we know we have myocardial infarctions with or without COVID, and we have to look at what our targets. We have patients post-resuscitation with COVID. There's also a target for that, 94 to 98%. and even with other situations such as carbon monoxide poisoning. Having said that, once you have your patient who is critically ill and acutely hypoxemic in the hospital, you have to quickly think of which is the best modality to use. And in a patient whom you are not sure if they are in a pre-arrest situation, then you must consider whether to just put in a Lysavir mask or use bag valve mask as advised by local or institutional resuscitation guidelines. These are the patients who are not at the risk these are the patients who are at the risk of arrest because they are critically ill. For those who are not, then you have to consider if they have a risk of hypercapnic respiratory failure or not, and then aim at the specific targets, either 88 to 92 or 94 to 98%. This is also a good flowchart, and this flowchart tries to look at how to manage a patient sequentially and also how to monitor them. Dr. Well did mention about the role of the arterial blood gas and how that helps us to determine which intervention to put in place. Those with the risk of CO2 retention, we may be able to allow PCO2s much higher, up to 6.0 kilopascals. This is about 55 to 60 millimeters of mercury. But we have to also realize that various of the gadgets that we are going to discuss here will be able to deliver valid level of oxygenation for our patients. So let us look at the devices, and probably we can discuss more which patients will require which type of devices based on what these devices are able to deliver. And we need to understand what they are, how they work, when to use them, and need to differentiate what is a flow rate and what is FiO2, that is a fraction of inspired oxygen. And also identify a patient's need for oxygen. We can classify oxygen devices in two main groups. There are what we call the low flow devices, and we also have the high flow devices. The low flow devices are probably what is more common, and that is what we use more commonly in our units. We have the nasal cannula, simple mask. We have the non-rebreathing mask. Some of them may be partial breathing. And what you will note is that this may not meet all the inspiratory flow demands, and the prescription is in liters per minute. With the high flow devices, starting with the venturi mask, the high flow nasal cannula, and the aerosol mask, and also what we call the tracheostomy masks or collar, this may provide the entire inspiratory requirements of the patient, and these are prescribed in fractions of inspired oxygen, that is FiO2. This is a simple depiction of nasal cannula. We all have used this with COVID patients, either initially or when we are de-escalating or weaning off patients from oxygen therapy. It can be used for both type 1 and type 2 respiratory failure. And we typically use about 1 to 6 liters per minute in terms of oxygen. You will note though that once you go beyond 4 liters per minute, then the risk of aerosolization is significant. And that's why with COVID, we are trying to limit this to 4 liters. But if you have a patient, for example, you are weaning off who has already turned negative, then you can go up to 6 liters. They are comfortable, easily tolerated, and there's no risk of breathing. Of course, there are costs and are quite preferred by patients. Looking at the percentage oxygen that you are able to deliver with this, 1 liter gives you about 24%. That is in comparison to the 21% that we get from atmospheric air. And by the time you're getting to 6 liters, then your maximum FiO2 would be about 44%. The simple face mask, this gives medium concentration, has a variable performance, also can be, or is mostly used for type 1 respiratory failure. It can deliver oxygen saturation or concentration from 35% to 60% with flows of between 5 and 10 liters. You need to use more than 5 liters with a face mask to avoid carbon dioxide building up and resistance to breathing. So this is just a depiction of the percentages in terms of FiO2 that you're able to get with different flow rates. 10 liters will give you about 60%. The non-rebreather mask, I know we are using this quite often, and this is mostly for now the more critical illness, critical COVID-19. We use it also for trauma patients, post-cardiac or respiratory arrest, and you can deliver up to 80% of FiO2, at times beyond that, with the non-rebreather mask. It is effective for short-term treatment and high flows of above 15 liters per minute with this high concentration mask does cause a lot of dryness of the mucous membranes, which at times does cause problems with breathing in terms of gaseous exchange, because it dries the airways significantly. Having said that, there is the Venturi mask, which is a fixed performance mask. I know this is not commonly used in our setup, but this is a high flow device, and it's able to generate much higher flows than what you get with the non-rebreather mask. That is despite the fact that we use up to 15 liters per minute of oxygen. And 15 liters per minute of oxygen is equivalent to what we call a 60% Venturi mask. They are colored such that each of these relates to a percentage FiO2, which is also equivalent to flow in liters per minute. For example, the white one is 28%, equivalent to 4 liters per minute, as compared to the one on the far end, bluish, which is 60%, equivalent to 15 liters. And how does this work? It works by generating a jet of air that is through apertures on the valve. You're giving oxygen through the port, and then you have an air oxygen blend, which is able to eventually increase the flow. For example, if you have a 24% Venturi mask with a flow of 2 liters per minute, you actually get a gas flow of up to 51 liters per minute. This also describes how that is achieved in terms of air entrainment pod, and the fact that the jet of air from room air helps generate a high flow. Titrating oxygen up and down using different gadgets, it's important to remember you can use a Venturi mask in place of a nasal cannula or in place of a simple face mask. And this chart just describes how you can titrate either upwards or across to give the same kind of oxygen delivery. We have the tracheostomy mask, which is also high flow, and this is for patients who require prolonged oxygen usage, usually with humidification, and these are patients who will have already performed tracheostomies during the weaning process. This is also a description of the same, and we also are able to give more than 8 liters per minute of oxygen. And remember, with this, you need humidification, as you usually bypass the natural humidification system of the airway. With humidification, you can use this with the different gadgets. We do have the simple ones that we use with the rebreather, non-rebreather masks, but we also do have gadgets that are specifically designed to provide humidification. And this may be advised by the physiotherapists in situations where it is of utmost importance. A good number of COVID patients have been shown to have significant crusting. You all know about research in South Africa, which indicated a lot of crusting, and it was actually shown that humidification can reduce the risk of crusting. We do have the high flow humidified nasal oxygen. This is also a form of high flow oxygen delivery device. It has become more common with COVID-19 due to, of course, the unavailability or the shortage of ventilators. This is an important gadget both in ICU and high dependency units, also in pediatrics. And the machine involves having a gadget that is able to, in a very controlled manner, one, warm the air that you're going to give the patient, then two, humidify that air, and then three, generate a much higher flow than the oxygen that is coming from the wall. And what you have is basically a gas blender, a humidification system, something to heat, and then the delivery gadgets, which is a heated circuit, and now the nasal cannula, which fits just like the simple nasal cannula onto the nose. These are the two main types available, but I do know there are other brands in the market. What we use is the Fisher Peka Airvo 2, which has very good tolerability with our patients. So you have heated and humidified air. It can better meet the patient's demands due to an increase in respiratory flow, and it is very good with increasing functional residual capacity. It is also important in washing out dead space, so it reduces the risk of CO2 retention. This is just a comparison of NIV with CPAP and high flow nasal cannula. I'll not go into the nitty-gritties of this, but the importance of high flow nasal cannula is that you have humidified high flow oxygen, which is able to reduce dead space. And the fact that the air is warm and humidified, it is also well tolerated by the patient. The level of PEEP you get with the high flow nasal cannula is of course much lower as compared to NIV, but it's significant that you can get up to 8, at times 12, depending on the kind of gadget you are using and how well fitting the gadget is. There's a new method of improving oxygenation with both NIV and the high flow nasal cannula. And this is what we call the Optiniv method, where you incorporate NIV and high flow. On the left is the high flow, on the right is the NIV with a mask. And when you use the two gadgets, it's been shown that you're actually able to reduce the chances of your patients requiring mechanical ventilation eventually, as compared to using each of these gadgets independently. The high flow nasal cannula has been used initially or as an initial intervention, and this is for patients who are likely to respond more positively. They do not have a lot of comorbidities. CT scans do not show significant lung involvement, and they are fairly on low levels of oxygen. And by using the high flow nasal cannula with these patients, they are likely not to deteriorate, and therefore not require mechanical ventilation. NIV per se can be used in two forms, either with a face mask or with a helmet. We have used helmets quite a lot in our unit, and I would say with very good results as compared to the face mask. It is better tolerated than the face mask. Your patient is still able to eat. As you can see, we are able to push in an esophageal tube, either through the nose or just a tube that the patient can take orally through the mouth. Then there is, of course, the fact that the patient is able to still communicate, talk to you, despite being on a PEEP delivering oxygen gadget. So this is very useful, and hopefully we can get more of this. The advantage of the helmet is also it can be used with the wall oxygen, with the Bosniak extension, which is basically just a valve that enables there to be a PEEP within the chamber, and therefore can be used in situations where ventilators are a big challenge. The only concern is the availability. The masks are more available than the helmets. I know the helmets we have been using were a donation through the Respiratory Society of Kenya, but I do know also that there are lots of efforts to have them available commercially for use. It's a gadget I would recommend for units who may not have adequate ventilators. Invasive mechanical ventilation is, of course, the last resort if you are not able to achieve your oxygenation targets with the low flow and high flow oxygen delivering devices. And this will include either an endotracheal tube or a tracheostomy tube. This may be done initially if your patient comes quite sick, but the tracheostomies, we tend to do them later when we are weaning patients off mechanical ventilation. So the most important thing is you have a ventilator, you have connecting tubes, it could be single or double limb. You also require humidification for most of these patients. It's very important. The aspect of filters also very important, especially with COVID. And also the aspect of feeding your patients during mechanical ventilation is very, very important. We look into the details of mechanical ventilation in our next or our following webinars on this particular topic. It's important to remember or to note the standard abbreviations for all these gadgets, as from CPAP, NIV, tracheostomy, mask, CPAP face mask, and all that. You should note there's a slight difference between CPAP per se and other forms of non-invasive ventilation, because with CPAP, it's the patient's own respiratory effort that drives ventilation. But with other modes of NIV, you are able to set, amongst others, PEEP, pressure supports, and also IE ratios and respiratory rates. And that may be indicated for different types of patients. We will also discuss that more in our next webinars. We all have to remember the oxygen flow meter in terms of target oxygens and where the ball should be. This is the right way to set 2 liters of oxygen. The ball should not be flowing above, it should be light within that mark of 2 or 3 for that matter. I see a lot of patients who are said to be on 15 liters, but the ball is way, way above the 15-liter mark. It means you're basically giving a lot more than 15 liters. Remember, we said giving too much is also harmful, and you have to be careful. Also important to know that you may have different air outlets, and it can be catastrophic if you put in a patient in an air outlet or medical air outlet and not an oxygen outlet. It has happened, and of course with catastrophic results. What devices to use, flow rates, and what are the situations? We know we have severe pneumonia as a big consequence of COVID-19 infection. And this is, in most cases, requiring flows much higher than a simple face mask to start with. But remember, our patients may also have pulmonary embolism despite having COVID. They may be in sepsis and in shock. They may also be, or they may also have had major trauma and just been found to have COVID as by the way. So we have to remember that there are different situations where you need high levels of oxygen. This is just a summary of where to use oxygen and which devices to target. Of course, the higher you go, then the higher the oxygen requirements, and of course, the higher the risk of requiring mechanical ventilation. So we have to escalate our oxygen use from a simple nasal plunge or from no oxygen to intubation, and that will be dependent on disease severity. Dr. Awel tried to describe this flow chart where you initially start with non-invasive strategies when you have worsening hypoxemia despite the use of non-rebreather masks. And here you may also try to use, or you will try to use a high flow nasal cannula with or without ploning, and also non-invasive ventilation. And when this fails, then you have no option but to think about invasive mechanical ventilation. There are various kind of ways of monitoring a patient's response to these interventions, which we're going to discuss briefly. So how we discuss this is we need to monitor the oxygen saturation. We need to know which device we are using and which flow rates that we are delivering the oxygen at to deliver that target range. So the pulse oximetry is, of course, the baseline, as we discussed earlier. We can use arterial blood gases, the work of breathing, which has been described, and then also a very good clinical assessment of the mucous membranes. And then, of course, we have to remember that our gadgets may also malfunction, and make sure that we monitor them, the servicing, the usual servicing. So the oximeters, they come in various forms. We now have smartphones and smartwatches that can do that. We have adhesive pads, which can also do that. But the typical transmitters we have are the wireless pulse oximeters and the tethered pulse oximeters, which come with the ventilators. The principle of this is spectrophotometry, where it looks at relative absorption of red, usually absorbed by deoxygenated blood, and infrared, which is usually absorbed by oxygenated blood in the or during the systolic component of the absorption waveform. In a picture, this is how it happens. You have the two diodes that release different types of light. You have the receiver on the other end, and it's able to pick the absorption of the two different lights is what is transmitted as an SpO2. There are many sources of error, and this is important because if you're not monitoring your patient well, you may not realize when you are getting into trouble with oxygenation. Is it that you are not delivering oxygen well, or is it the pulse oximeter that is faulty? The first thing is, of course, to make sure the pulse oximeter is working well before you adjust the oxygen delivery rate or mode or flow in that case. So it cannot differentiate the various forms of hemoglobin. So if you have a lot of carboxyhemoglobin, it will still be registered at 90% oxygenated hemoglobin. If you have significant venous pulsation, then you'll be getting an error. There is a lot of pulsation with that. If you have environmental interferences, either with movement or vibration, or a lot of ambient light, when patient is in shock and has very cold extremities, then you'll get errors with nail polish, and also when you have intravascular dyes such as metherythonium chloride, then you'll have ALAS as well. So that's just a typical or two typical gadgets. We mentioned the 4 major groups of patients where we require oxygen. In our situation, we have critical or serious illnesses, but we also do remember our COPD patients who may also come in as COVID. So when we are monitoring oxygen delivery, it is good to have this kind of charts on the or by the bedside. It's something we are trying to introduce in our unit, despite the fact that we do not want to have a lot of lighting, but this can be by the patient bedside, meaning this is a dirty area and this does not leave the dirty area. You have the respiratory rate, oxygen saturation, and the mode of therapy quite well documented in that. We have mentioned what are the normal range and what we should target. I'll not belabor that, but the aspect of nocturnal desaturation, I think, is important for our consumption. This is because we leave patients on fairly low levels of or low amounts of oxygen therapy in the evening, but by morning we find most of them have gone higher. And this is because most of us have desaturation at night of about a standard deviation of about 3.1%. So your patient, despite having COVID, they will also desaturate more when they are asleep, despite also being on oxygen. So this should not be worrying. I think the idea is to wean them off further during the day and make sure that you basically have an upward general tangent, not lower. When we talk about why should we maintain optimal saturation, meaning not too much, not too low, meaning hypoxia. If you have too much of oxygen, then you are generating superoxides, which we know are harmful. If you have too low, then you are into anaerobic metabolism, which we know has its harmful effects as well. And when you look at the hazardous or the hazards of excessive oxygen therapy, they are quite immense and they may have significant effects. For example, if you have retinal damage or hypoxemic acidosis, death, endocrine effects such as to the adrenals, the gonads, and thyroids, including renal damage, hepatic effect, then it's not something to take lightly. And we should always aim to use oxygen just to achieve the required targets and not more. So the general principles of assessing the respiratory status, it's important for the patient not to know that you are assessing their breathing in terms of how you count that. It's important to assess effects of sudden hypoxemia as compared also to those of chronic hypoxemia. I think Dr. Waero has elaborated this. I'll not go into details. But what is important is to use the different modalities, not just one, to determine your patient's general status. Whether it is the observation or clinical examination, the blood gases, all by doing what we call indices. And one of the indices we use is the respiratory rate oxygenation index. This is usually for high flow nasal cannulas. It determines whether or not your patient is responding well to the high flow nasal cannula and the risk of requiring mechanical ventilation. So if you start the nasal cannula and within 12 hours, your respiratory index is more than 4.88, based on this formula, then your patient is unlikely to require mechanical ventilation. But on the other side, if these are your indices, then you have high flow nasal cannula failure and you need to start thinking about mechanical ventilation. The other one, which is good or very important, is the PF ratio. And this is a ratio of the PaO2, or the partial pressure of oxygen, to the fraction of inspired oxygen. And normal would be about 476. But looking at the Berlin definition of ARDS, then we have 3 categories of mild, moderate, and severe, where mild would be between 200 and 300, moderate 100 to 200, and severe below 100. Remember, with this, you need to do a blood gas to determine the partial pressure of oxygen. So what you can use as an alternative, the Kigali modification, and the Kigali modification looks at SpO2 with, or it's a ratio of SpO2 to the FiO2. With this, you do not require to do a blood gas. And with that, then you can determine what kind of intervention your patient needs. If you are in mild ARDS, then of course, non-invasive ventilation will work. If you are in moderate, then you are already thinking about mechanical ventilation and other interventions to improve oxygenation. For example, the higher PEEP, neuromuscular blockade for those who are not synchronizing, prone positioning, and with very, very severe hypoxemia, then you go for much complex interventions such as ECMO, which we are about to commence in our institution. So one of the ways of improving oxygenation is ploning patients, both for ventilated and non-ventilated. And this is just a pictorial depiction of that. It is very important. And the importance of that is you are dealing with the VQ mismatch that Dr. Awero described, where you have areas of atelectasis. And when you turn these patients such that these are the areas above, then you have more aeration of lung where blood flow was already present. Because with the shunting Dr. Awero mentioned, you have areas of lung where blood is flowing, but there's no air. So there's not going to be any air exchange. And that's the VQ mismatch that we are talking about. The other thing to remember, of course, is other than the physiological dead space, which we have described, is the mechanical dead space. And with the mechanical dead space for ventilated patients, we have various ways of reducing that to improve oxygenation. There are a few contraindications to cloning. One of them is issues to do with intracranial hypertension. That is fairly absolute. And then the relative ones. But remember, even with early semesters or early pregnancies, it is possible for patients to clone. But with late pregnancy, then an obstetric consultation is mandatory. So if you reduce the mechanical dead space, or if you intervene to reduce the physiological dead space, then you're able to improve the patient's oxygenation. So in summary, with oxygen therapy, it needs to be prescribed. We need to have target groups for target saturations for the two main groups. We need to administer oxygen only to achieve the target saturation. We need to monitor oxygen and keep it within the target range. We need to taper oxygen dose and stop when not needed or when stable. And then we need to audit our practice and eventually institute measures always to improve oxygenation. Thank you for listening.
Many thanks, Dr. Kioma. Again, a fantastic presentation. We've learned a lot, and I'll highlight one of the things I learned. You know, usually when we go to a unit and a patient is on a non-rebreather mask, people keep titrating down on the non-rebreather mask. So someone is on 8 liters, still on a non-rebreather, on 5. So I think that importance of when you get below 10, we need to change the device is so important. And so many other excellent lessons. And I think many of those have also answered some of the questions that were in the, on the platform. So thank you, Dr. Kioma. Thank you, Dr. Awero. I think now we'll just go to a short discussion sessions. We just have about 10 minutes to the end. So for Dr. Awero, Dr. Awero, you're still with us?
Yes, I am.
Yes. Yes. So one of the questions someone has asked is, what are some of the causes for deterioration post-discharge? And I think the thing about that patient who you think has done relatively well, you send them home and either they come back or they don't do well, or you hear that a patient was discharged, has died. So what are some of the things that people should be looking out for to avoid that?
Yeah, thank you for that question. And it's a pertinent question. When we discharge patients, the assumption usually is that they do not need, one, the very regular monitoring that happens in hospital, two, their disease is stable and improving, and number three, any of the life-threatening risks are over and not likely to recur. However, with COVID, several things can occur. One, the disease does not always follow a linear progress, meaning that the patient required 10 liters of oxygen, now is 8, next is 5, next is 3. Sometimes we do see patients who have increasing requirements even after they have had a progressively required need for oxygen. And this could be due to, one, an increase in new inflammation due to the COVID infection. Remember, we sometimes stop medicines like dexamethasone when a patient has been in hospital for 10 days, and that can lead in a few patients to recurrence of progressive inflammation. Number two, these patients who have required oxygen have received steroids, and these steroids are immunosuppressive, and they can pick other diseases in hospital, including pneumonia, sepsis, and so on, and that can lead to deterioration at discharge. Number three, other complications that may occur like pulmonary fibrosis, which can impair oxygenation. Number four, pulmonary thromboembolism is a common killer for these patients who have gone home, especially if they have spent time in bed, not moving around much. And when they go home, we forget to give them some anticoagulation for a period of time. So there are many reasons really why a patient can deteriorate when they are going home. And remember, during the discussion, I mentioned that some patients will be off oxygen, saturating very nicely above 90 when not exerting themselves. Then when this patient goes home, he remembers there are some social functions he needs to do. Maybe he needs to go to the bank, or he needs to go pay school fees, or things like that. And when they exert themselves excessively, that leads to hypoxemia and patient deterioration. So many things that need to be looked at when patients deteriorate. And even when they come back to hospital, let us remember COVID itself could have gotten worse, but other comorbidities may have been exacerbated or may have arisen during the time when this patient left the hospital for home. So very important that when you are sending patients who have required oxygen, and even those who have not required oxygen, let's remember they may deteriorate. Ask them to monitor themselves, maybe using pulse oximetry, thermometers, blood pressure machines if they are hypertensive, and sugar measurements if they are diabetic or they have gotten diabetes during the COVID infection. Thank you.
Thank you very much, Dr. Oweru. And maybe just to bring Dr. Kioma in, one of the questions is, if you have a patient on oxygen, how fast or how slowly should we wean off? Say you have a patient who is on 15 liters via non-rebreather mask and is stable, doing well. Do we take it down by 1 liter per day, 2 per day, 5 per day, per hour? How do we decide what's the appropriate way to wean off?
Thank you. That's an important question, and also a challenging situation, I know, for most clinicians. And this is because we are saying on one side, you should not give too much. Give too much, it's harmful. So you need to have a kind of more standard way of weaning patients of oxygen. The first thing is there's no specific timing in terms of after how long should you wean a patient down on oxygen. But I'm assuming most of our nursing procedures, we have timelines. For example, every 2 hours, 4 hours, every 6 hours, we do something with these patients. So with COVID patients being in isolation, we have to be practical and use our interactions with the patients to do this kind of weaning. Having said that, if a patient comes into the hospital and you have started at 2 liters of oxygen via nasoplugs, and their saturations pick up to your target range. So it means you do not have to add. But let's say your target is 94% and you are achieving only 90 on 2 liters. Then the idea would be to increase the oxygen. It doesn't matter whether by 2, 3, or 4, but one would assume how much oxygen do you need in terms of FiO2 to achieve 94 if you're already at 90. Remember, we gave that chart of how much FiO2 you achieve with different flows on the nasal cannula. So using something like that, you're able to say, okay, and I need to increase from 2 liters to 4 liters to achieve an FiO2 of 28 from 24%, and that way I'll be able to achieve 94% saturation. The one thing I've noticed, which for me is a big concern, is there's a tendency to put all patients on more than 15 liters of oxygen. And I don't know whether it's out of fear or it's just instinct that you want to give a lot of oxygen. And you find once you reduce to just 15, patients still do very well. And then you can start going down slowly. The weaning process does not just depend on FiO2 or on SpO2. It also depends on how well the patient is doing in terms of the clinical examination, the work of breathing, amongst others. And then, of course, if you're in a situation where you're able to do blood gases easily, then that becomes the easier way to monitor and decide when to reduce the oxygen. Most patients in our ICU who require frequent blood gases, we put arterial lines so that we don't keep pricking them. So it makes it easier to do blood gases often. I hope I have answered the question.
Thank you very much, Dr. Kioma. So let's say I'm a clinician at the hospital and my patient is on 15 liters. So I'm just pushing this because it's a question that's often asked, and is at 94% and has done well. The first time I go and decide I want to wean off, do I take it to 14? Do I take it to 10? Where do I start from?
It's difficult to have a specific kind of weaning for oxygen. It's because you only wean as tolerated. But if your patient is on the target, if that's the lower limit of your target, 94, then you cannot reduce that oxygen significantly. So you may decide to reduce just by a liter or 2. But there's also that aspect of observing the patient there and then and determine whether they have tolerated the weaning or not. Because you may reduce by 1 and they don't tolerate it. You're not going to, just walk away. You may reduce to 14 and then observe 3 minutes. Of course, not immediately. You have to give time, about 3 minutes. If the saturations are still 94, then you are good. If they are not, you have to go back to the 15.
Okay, thank you very much. I think the one thing we need to sort of agree on, we've had sort of different figures for targets of oxygen therapy. We've had 90%, 90 to 92, 94 to 98, 92 in pregnancy. What should we go with? What should be our take home? What is safe? Dr. Waweru?
Thank you. What I would like to refer people to is the oxygen curve that Dr. Kioma had shown. And what we notice is that after the saturation—
Sorry, Dr. Kioma, please go scroll back and show that curve as Dr. Waweru is answering. Thank you. Dr. Waweru, sorry, go ahead.
Yeah, so let's get there. So once you reach the 80s, you notice that it becomes flat. So generally, most current recommendations, as far as COVID is concerned, are talking about 90 to 94%. Let's just look at it. Yeah. But there are special, yeah, there, you've passed it, Kioma, thanks.
That one.
Yeah, there, that's where we are. So you'll notice that if we look at this level, the moment you hit 90, your PaO2 is above 60 millimeters of mercury. And for most practical purposes, that will be adequate for most people. except in patients, for instance, who have got COPD, where you can take 88% if that is their usual baseline. In pregnant women, you may want to go a little higher, maybe from 92 to 95. But generally, that is where we would like patients to be. Dr. Okioma, I have a comment.
Probably just to add to what you have mentioned, and by the time you get to 100 FiO2, not FiO2, but partial pressure of oxygen, then that's the point where you start getting the hazards effects of oxygen therapy. Generation of those peroxides that we said are harmful. So by the time you're getting to 100 FiO2, then you start thinking, no, I'm now getting onto the negative. Yeah, that's what I wanted to add.
Thank you very much. I've noticed that people really like nail polish. Everyone is very concerned about this issue of removing nail polish, but I think it's been clear, was presented last week and this week, nail polish may not, if someone has nail polish, you will not get accurate readings and it should be removed. There was just one other question. And someone asked about issue of baseline tests, and someone asked, should they do a creatinine as baseline? Does it predict? Why do it? And what are the relevant baseline tests? So we'd mentioned this briefly just after the case presentation. In a patient who's severely ill and you're admitting into the hospital, you probably want to have renal function test. Why? Because you know patients will often get other organ issues. And if you do not manage those, then you may be pumping in the oxygen, but losing your patient to other issues. So there are things that help you to ensure you give patient appropriate care. So for example, the UECs, we've noted many patients may have some level of hepatitis and you may be giving different drugs. So it's important that you know what the LFTs are, especially if you're going to be giving very frequent paracetamol, for example, which may also be hepatotoxic. So some of these are important because they help in the direct patient care. There's some lab tests that are not necessarily useful. In the past, we've noted people are doing a lot of ferritin, and it's probably because in the beginning it was suggested that high ferritin was a predictor of poorer outcomes. But then again, there's nothing you're going to do about this ferritin. It's not going to help you manage this patient any differently. So it's probably one of those tests that you shouldn't do. The D-dimer, again, as we said earlier today, a D-dimer, you're likely to find a D-dimer in a high D-dimer in most of your patients with, you know, a lot of inflammation in COVID. On its own, it doesn't help you determine whether a patient requires anticoagulation. Earlier on in the COVID outbreak, it was suggested that patients of higher D-dimers may require higher doses of anticoagulation, but that has been shown not to be true. So having a D-dimer may not be useful for your patient. If you think your patient has a PE, then you may need imaging for that. As we said with the CRP, and we say this because it's one of those that people tend to repeat over and over. The CRP is likely to be high anyway, because there's a lot of inflammation in patients with severe disease. It's probably only useful in determining whether you want to give things like tocilizumab, for example, in patients who are acutely deteriorating. But outside of that, it may not be very useful for taking care of your patients. So maybe as we finish off, I'll ask Dr. Oweru and Dr. Okioma if they have any last words to advise people who are prescribing oxygen, just your take-home message for today. Dr. Oweru?
Thank you, Dr. Lois. There's someone who asked about complications of oxygen toxicity, and clinically, the patients will generally have worsening cough, chest pain, throat irritation. They may have worsening dyspnea, not because the disease is worsening, but because they are getting oxygen toxicity. Dr. Okioma ably discussed the development of reactive oxygen species. Then dizziness, blurring of vision, and confusion. So these are real complications which may occur, which one must think about. But to summarize, I think as far as oxygen is concerned, let us first of all educate our patients why they need oxygen. Let's look out for people who need oxygen, and let's remember to wean off as and when the patients start improving. Thank you.
Thank you so much, Dr. Oweru. Dr. Okioma?
I've shared the slide with the summary on the hazards of too much oxygen. They are quite severe and extensive. Having said that, we need to also recognize the constraints in terms of the availability of oxygen. And as such, we have mentioned that oxygen is a drug, should be used sparingly only when indicated, because we also need to maintain the supply chain, and wasting or being wasteful, of course, will bring a big strain on the supply chain. That's all from me.
Thank you very much. I think we have learned so much from today's session. We'll continue with this oxygen series next week. If I refer back to the case that Dr. Juma presented, this is a patient who was referred from Nyeri. It was Nyeri, right? Yes, from Nyeri. And by the time they got here, the oxygen saturations were very low. So one of the things that we'll be talking about during the next sessions will be issues about identifying the patient who requires early referral and how to safely refer, transport, transfer patients from one unit to another. So tune in next week. We'll have more. Invite your colleagues, invite people you know who are managing patients and requiring COVID. I'd also like to acknowledge Dr. Maritim, who's here with us today. She's waving, though you can't see her, but she's waving at all of you. Thank you all for joining. It was an excellent session. Thank you, Dr. Thuranira, for very ably organizing and coordinating this session. We want to wish you all a very good weekend. Bye, everyone.
Goodbye.